Tamara, and welcome again to our webinar about capnography with bellavista, but also capnography in general. Today we're talking about the basics of CO2 monitoring, how it works, what you can achieve with it, and some also tips working with bellavista and also the different capnometers we are offering. So for today's session, or better after this session, you will be able to describe the process how CO2 is generated, and you also can interpret basic End-Tidal CO2 waveforms. So just let's start. So before we talk about capnography in general, I would like to have a very short trip, and it won't hurt, into anatomy and physiology, and just to describe what's really happening during respiration. And if you look at the respiration process, we have cellular metabolism, things going on the cell level, because this is where the energy has go to. And also when the energy is consumed, there will be waste. And the hemodynamics is transporting the waste product, but also the nutrient products to the cell level. And also the lung plays a big role into exchanging, for example, oxygen and also eliminating CO2. So we have two processes referring to the lung. First is oxygenation. We just want to get oxygen into the lung, and when it comes to ventilation, there are two controls and settings referring to that, which is mainly the PEEP and also the FiO2. So the level of oxygen I set on a ventilator, for example, is also determining how the patient will be oxygenated, and the PEEP will maintain, or hopefully maintain, stable conditions for the oxygenation of the patient. On the other side, we are talking about ventilation, and I already talked about this process also a bit during the AVM webinar. So we have oxygenation, ventilation, and responsible for the ventilation and eliminating CO2 from the body into the air, into the atmosphere, is just the minute volume. And the minute volume is something summarized, which could be coming from the rate, from the tidal volume, from the inspiratory pressure, but all of them, they are just contributing at the end to the minute volume. So where does the CO2 come from? So we are eating day by day, several times a day, and we have three different nutrients which we need to have, which would be fat, proteins, and carbohydrates. There is a fourth one, which would be alcohol, but I didn't put it here because alcohol has a bit of a different process, but it's also kind of a nutrient, but it will also be directly converted into fat. But then that's the reason why I didn't put it here. And these three different nutrients, they are processed in the human body, and what's called the citric acid cycle, or it's also called the Krebs cycle, which was a German researcher beginning of last century. And he found out that, you see, in a rather complicated process, at the end we have one product which gives us energy, which gives us all the energy we have, which is adenyl triphosphate. And there are waste products, which would be CO2 and water. And watch closely that cycle, because I will have a lot of questions at the end of the webinar about this. No, I'm just joking. It's really complicated, but the takeaway message would be ATP is our fuel. This is where we get the energy from, and the waste products are CO2 and water. And looking at the waste products, also the waste products, they are also eliminated through other organs like the liver, the kidneys, and also the intestines. But the CO2 goes entirely, is entirely eliminated via the lungs. And in the second part of the webinar, we will talk about more this elimination process. Today, it's just a general overview. So when we have a look into capnography, we will have a direct look into that elimination process because the amount of CO2 eliminated through the lungs gives us a clear insight into the process already with the time-based capnography, even more with the volume-based capnography, which will be the topic of the second webinar. And you see we have the three levels again. We have the cell, we have the transport, and we have the lung. And there are differences in the elimination and also in the concentration of blood gas, CO2, and also end-tidal CO2. So what we breathe out is not entirely the same what's in the blood. So usually the partial pressure of the CO2 of carbon dioxide in the arterial blood is usually in a healthy human between 35 and 45 millimeter Hg, and it's lower on the end-tidal CO2. End-tidal CO2 means that at the end of the exhalation, that's the concentration you measure with capnometer. And it's lower because the concentration, because of some dead space things going on, we will always have, even in healthy humans, areas which might be ventilated but not perfused, and that's the difference, or what officially is called a CO2 gradient. So if the EtCO2, for example, of the ventilator is showing a higher concentration than the blood, there must be something wrong. It always has to be lower than the blood CO2. Hypercapnia, this is just about the whole definitions. That's only saying that there is a higher CO2, and hypercapnia can, for example, caused by a high respiratory rate. But for example, hyperventilation. So if you hyperventilate, no, it's totally wrong. Just forget it. Hypercapnia is a higher CO2 because the patient is not ventilated enough. So there is no elimination of the CO2, and that lets the CO2 increase. The other way around is hypocapnia, and that happens when you hyperventilate the patient and just eliminate on a higher level. And the patients are only hypo or hyperventilated when it somehow affects the CO2. I've come across since many years about visiting sites where they say patient is hypoventilated or hyperventilated just because of the respiratory rate. When there's a high respiratory rate and the CO2 is normal, the patient is not hyper or hypoventilated. So as long as the CO2 is normal, as long as there are no hyper or hypocapnia, whatever the respiratory rate is, it's not hyper or hypoventilated. The gradient, I was already talking about this, between the arterial and end-tidal CO2 is usually in a healthy human 5 to 6 millimeters mercury. And this is absolutely normal. When the gradient is increasing, there are processes going on. We will talk about this in the next session. But as long as it's in that area, and 5 to 6 millimeters of mercury is not that much, we can really say that the end-tidal CO2 is a good surrogate of the blood gas or the partial pressure in the blood, so that we might not have to use so many blood gas analyzers anymore when we are working with a capnometer. Okay, so now talking about capnometry and capnography. The whole process, but these were quite quite bulky machines, started in the 50s and on a regular basis in mainly anesthesia when the whole devices were getting smaller and smaller. Capnometry and later capnography was used from the 80s on. Nowadays, it's a must-have in anesthesia for certain reasons. It's also a standard. And unfortunately, it's not used on a daily basis in ICU and in ICU ventilation. It's what I always wonder about, that many people seem that this is not necessary because they have blood gas. But as I already said, it could spare a lot of money because blood gas analyzers are still quite expensive. And I still don't understand why capnometry and capnography is so rarely used in ventilation. And you can really monitor lots of processes when using capnometry, for example, perfusion changes. Also, you see a lot about effectiveness of what you're doing, especially when you resuscitate a patient. Of course, and that's the reason why it's widely used in anesthesia and also in emergency, that you really can confirm a correct placement of the tube, because when there is no CO2 coming back, something must be wrong. And also, and this is maybe not that most important, but you can also check on the ventilator circuit integrity, because when there is things going on which are not correct, you will also see this on the capnography. But it's always like whatever you do in ventilation, it's easy, it doesn't hurt no one, it's good to understand, but of course at the end you really need to know what you're doing and how to maybe interpret basic waveforms. What's the difference between capnometry and capnography? This is quite easy. Capnometry is just a numerous value, so I see, okay, the EtCO2 is now 39, which would be good. And you also see the signal strength on the capnometry, and that's all you get. And this is already, especially in emergency use, might be already enough. But you can get much more analysis out of the waveforms as well. So this would be capnography, because when you have a graphical interface which shows you the outcome and also the waveform of the expiration phase of the patient. And in bellavista, for example, we have a lot of parameters, and I will come to that later. And of course, we also have a capnography curve. There are various measurement technologies. There is, for example, the infrared absorption, which is, I would say, the mainly or mostly used one. There is a MCS, which is kind of a laser technology, spectroscopy, and there are also mainly used in emergency and ambulance transport. There are also colorimetric detectors, which just give you an indication if you have a correct tube placement by changing the color of a certain kind of paper, which as soon as there's CO2 flowing over, the color changes. I will just briefly explain that, for example, the infrared carbon dioxide sensor, like in mainstream capnography and also used in Sidestream capnography, there is one side which is emitting infrared signal, infrared light, and on the other side that light is absorbed, and there are two filters, and the filters are in the capnometry adapter. So if you use a mainstream capnography and you have the adapter there, I always hear that this adapter is sometimes used twice or maybe a bit more often, which is you might imagine can also impair the effectiveness of the CO2 measurement, because these two optical filters, when they're somehow affected, for example, by nebulization, by there are scratches on it, or whatever could happen to this light source won't send the right signal anymore because it's impaired by the wrong adapter, or not by the wrong adapter, by maybe a defective adapter, and so you will get funny values. And when you use, for example, nebulization, the light is emitting differently because of the nebulization, so probably or potentially the result will be impaired as well, or affected as well, or the capnometer won't even measure anymore. And so it's very, very important that the adapters should be always new, always used once on a patient, to just guarantee that the CO2 measurement is going smoothly. And that's the reason why we need this adapter, and otherwise without the adapter the capnometer won't work. The second one is this MCS, which is claiming, because they are working in a kind of Sidestream measurement, which will come in a minute. So they are sucking gas out of the airway, and with having a laser-based technology, which is perfectly matching the infrared emission of CO2, this is claimed to be very, very precise, and also they don't need much of a sample size. So they say it's 50 milliliters per minute. It's a bit lower than usual Sidestream devices need, but I don't know about any mainstream capnometer, and I don't think, except in neonatology or in Sidestream's technology, that it's widely used in ventilation. And here we have the colorimetric sensors. You see there is a kind of a paper, and here you see the different colors, and then you know about there is CO2 present, so my intubation was done correctly. And when this paper is not changing the color and keeps like this, you know that the tube placement is should be checked. And there is also the coloring showing you a certain level of CO2, but these are not the most precise instruments, so it's really only for ambulance transport. I don't think that this is used widely in ICUs. Talking about the different technologies, on bellavista we have a mainstream device, and we also have a Sidestream device. Both are coming from Massimo, and Massimo has bought a Swedish company which was called Phase-In before, and so this is the Phase-In technology, and we will come to that in a few slides, what the advantages of this technology might be in comparison to other capnometers. But just talking about mainstream, the biggest advantage is in comparison to Sidestream, it does not take gas away from the sampling side, so this won't affect much on an adult patient, 50 milliliters per minute, but it can also already affect neonatal patients, so it does not transport any gas away. The disadvantage is it adds to the apparatus dead space, or the mechanical dead space. So for adults, it's 6 millimeters, which is adding to the dead space. There's also pediatric one available, which is only 1 milliliter. And at the end of the day, it adds dead space. So that's one of the disadvantages of mainstream monitoring. But the graphical representation, the curve of mainstream monitoring is fast. There is no delay because of like in Sidestream monitoring. And so this is, I think, in ICU on adult and pediatric patients, the mostly used technology. When we go to Sidestream, which is also the ISA infrared Sidestream, so you have the Sidestream on the ventilator somewhere, and then you have a sample line with a filter. The filter is just preventing that fluids are coming into the Sidestream device, and the whole measurement is done inside that device. But of course, when you have 2 meters of sample line, there is a delay in measuring, and it can be 50, it can also be a bit more than that, so this can really affect also the ventilation a bit, because this is gas which is kind of a leakage, and it's not coming back. So these capnometers Sidestream capnometers are really sucking the air before it reaches the patient. And on the good side is that when you have fluids on the mainstream, you will always have alarms, because the fluid, as I already explained, is affecting the measurement. This doesn't happen too much on the Sidestream, so this is an advantage of the Sidestream, that it's not so sensitive against fluids. And as I already said, there is a delay time because of the 2 meters sample line, which has some seconds to get through the infrared monitoring unit, and so we always have a little bit of a delay. So it's not that exact like in mainstream capnography. Are there questions so far?
Dear participants, if you have a question, just use the chat window. Please send us your question in the chat window, or click on that raised hand icon on the bottom of the participant list. No questions so far.
No questions? Okay, good. Then I will carry on. So now we're talking about the capnography waveform, and for me in the beginning it was always difficult, because having, for example, a pressure airway curve above and the capnography waveform below, the waveform is showing the expiration phase while the airway pressure is showing the inspiration phase. So sometimes you have to think in the opposite way about this. So there are different phases of the exhalation which define the capnography curve. Here in the phase 1, it should be a baseline, so we don't want the patient ventilated to rebreathe CO2. This can happen sometimes when the respiratory rate is high, so the patient is not entirely exhaling, but the baseline or the phase 1 should be always on the baseline and should be at 0. And so this is also characterizing partially the dead space. When we're talking about volumetric capnography, the curve looks a bit similar, but it's not exactly the same, because we are just having the time domain now. We don't have any indication about volume. Then there is a phase 2 in this time-based, which is marking that now the expiratory and there are fast emptying alveoli. So the expiratory phase starts, and also the alveoli are starting to empty. And so we have that called expiratory upstroke, so CO2 is increasing. Then there is the plateau phase, which is called the phase 3, and the plateau phase ends up at that point where the ventilator or the capnometer is measuring the EtCO2. That's the point where the EtCO2 comes from. They're not measuring here or somewhere else. It's always the highest point of the expiratory phase. And then there is the 4th phase. Inhalation begins again, and the curve goes back to phase 1 and to the baseline. And the whole process is the whole expiration cycle of the patient. We have the normal range of the ETCU2, which should be around 30 to 43 millimeters of mercury, or 4 to 5.7 kilopascal, and so we are in a good range of CO2. But again, the PaCO2 would be a bit higher on the same patient, even if this patient is lung healthy. So a normal waveform, this is how a normal waveform looks like, but there are deviations from that normal waveform, and also the shape of the capnograph also can help to determine the problem. And we have a slight elevation during the plateau. This is also a bit the heterogeneity of the lung and represents this. So it's a bit increasing during the plateau phase. So of course, when we have an increasing CO2, for example, you see that level here, the shape of the curve is the same, but the height of the curve is increasing, so that means there is more CO2 measured. This can have certain reasons, a decrease in respiratory rate, decrease in tidal volume, but also increase in metabolic rate, because when the patient, for example, has fever, the CO2 raises by 13% the CO2 production for each degree of Celsius of temperature. So if a patient has a temperature of 38.5 degrees Celsius, the CO2 production is raised by 13 to 15%. And this can also, even if the rate is not changing, can also be a reason for increasing CO2. And what I would always do is, because watching at the ventilator, you see only 3 CO2 waveforms, and you see a certain level of ETCO2, and you also have a numeric value. But more interesting is what CO2 is doing over time. So I always would recommend, when working with CO2, and always recommend to your customers that they also should have a look at the trending data, because the trending data gives you a real, not feeling, but a real monitoring about the course of time. So when the trend is showing you an increase over time, you know that there is something going on, especially when you didn't change the ventilation. So this is very important. The other way, and the opposite, and this I think is an easy one, is decreasing CO2. You also see the trending here. Now we're talking about hyperventilation. We could also have a decrease in metabolic rate. For example, a hypothermic patient. For example, when patients come out of a cardiac surgery, from cardiac surgery, they're mostly a bit cooled. So the CO2 is mainly very low, and when they warm up, the CO2 will increase again. And so this is what it looks like when the CO2 is decreasing. And again, look also at the trending. Rebreathing. You see always the normal here. CO2 comes back to 0 at the baseline, and the next exhalation phase is raises again. When the CO2 is not coming back to the baseline, there must be some rebreathing. This can have, as you see, several causes, but action needs to be taken here, because it's not healthy for the patient and not good if the patient is constantly rebreathing CO2, and you also see the trending in the same way, but not the top is changing, the bottom is changing. So do some troubleshooting when you see a curve like this, and try to get rid of that rebreathing for the patient. And for example, in anesthesia, this is often, very often, but now on modern anesthesia machines, you get other indicators that there is rebreathing going on, but in the past you could see that you had to change the absorber when the patient got CO2 in his lung again. Here you see obstructive patient, could be an asthma patient, could be, of course, an obstruction on the expiratory side of the ventilator, so that it takes longer and there is a increase in the not a decrease in the plateau. So that means the emptying of the alveoli, when we're talking about a cough coming from the patient, is much slower. They probably will still get to the end-tidal CO2, but the steepness of the slope is much lower than on a normal one. So the fast emptying alveoli, something's not working correctly here. Could also be something kinked, but from the ventilator on the expiratory side, but very often and mainly these are reasons from the patient who might have some obstructive problems. So the next one. This is not how it's looking when you have paralyzed the patient. This is how it's looking when the patient is starting to breathe again. So everything is fine from a CO2 elimination point of view, but on the exhalation, he is also again starting to inhale, and this is causing that cleft and that dip in the plateau phase, and then you have to decide if the patient should be paralyzed again or if he should come back to spontaneous breathing. And so the more awake or the more or the less paralyzed the patient is, the cleft could be bigger and bigger, but this can also happen when the patient is deeply sedated and the sedation is not enough, that those patients sometimes try to inhale again when they are ventilated with a mandatory ventilation mode. So if you see some of these dips or clefts, there is spontaneous activity coming from the patient, which alters the curve here. And this is how it looks like when you have done something wrong after intubation, or your intubation was not going on correctly. There might be a first breath where you get some CO2, but the second or third breath will go down to baseline, and then you immediately should know that something's wrong here, and the patient needs to be re-intubated. And I think that's quite obvious here. And then last but not least, when there is a tube leak, also the curve is not entirely looking correctly, because in the exhalation phase the air goes somewhere, and this is also represented in that curve. So maybe you have to block the cuff again, or you have to look for another reason for the tube leak, but this also gives you an indication that something's not working entirely well. And these are the basic curves on a time-based capnography, which you can easily detect and easily also now analyze. There are many more. I just wanted to show you the easy ones and most important ones, but already we have quite a good spectrum of detecting problems through the capnography curve. Next part, monitoring. When you're looking at bellavista, we have, and we will talk about this in part 2 as well, we have lots of values, which here are mainly coming from the volumetric capnography. I just want to go through them. The explanation for that value, for these values, will also be in the second part. But the first one is the part of the volumetric capnography, which is the airway dead space. Then we have the dead space per kilogram. We have also the ratio of dead space and tidal volume. We have the alveolar tidal volume. And then referring to the webinar today, that's the ETCO2. ETCO2 on bellavista is available in 4 different standards. It's millimeter mercury, we have hectopascal, we have kilopascal, and we have percent. But I think in most parts of the world, millimeter mercury is still used. Then we have the CO2 elimination per breath, which is the VTCO2. Then we have the CO2 elimination per minute. And we also have the other ones which are not directly related to CO2, but you see we have 7 values, which makes it very easy to understand the metabolism of the patient and also to optimize the ventilation. But for today, the ETCO2 is the most important, and this is what we're talking about today. But that's so that you're a bit prepared for the next capnography webinar, where we talk about the other volumetric values. Just as a summary, this shouldn't be your only monitoring, because we know maybe what's going on the elimination side, but we don't have any clue what's going on the inspiratory side. So you need another monitoring. You will have this with bellavista, but also the hemodynamic monitoring would be highly recommended. Like always, don't use things you don't know anything about, and you should have the expertise to use it. Think about the dead space on the bellavista in pediatric and also in neonatal. When you start CO2 measurement or monitoring, you always get an info message to think about the dead space. So this is just a reminder that you should take this into account, whatever configuration you have chosen. Just this adds dead space, and premature neonate sometimes can already suffer from 2 or 3 milliliters of dead space. Also on the Sidestream capnography. This shouldn't be done with anesthetic gases, mainly the mainstream and also the Sidestream. They are not prepared for anesthetic gases. So this is also very important when used, for example, something like the Anaconda, because anesthetic, the infrared units will give you wrong monitoring then, and it impairs the whole monitoring and measurement. So anesthetic gases, you should at least be aware that the CO2 measurement can be impaired. When you resuscitate a patient, take the CO2 off and disconnect from the device. Sure. When and this is something I always come across, patient has a very funny CO2, I have to adjust the ventilation in non-invasive. It's measuring the exhalation, but when there is a high leakage and 80% of the inhaled tidal volume is getting out beside the mask, your CO2 measurement will be highly impaired. So always take into account when using Sidestream, doesn't matter, or mainstream, that the leakage is taking out CO2 already. So those values might not be perfect, or most likely are not perfect. So only if you can manage to keep the leakage very stable, you might use CO2 measurement, but often it's not working very well. Okay, giving a summary. capnography assess proper endotracheal intubation and patency of the ventilation. It can monitor your course of the ventilation. So when you get clear signals, when you get stable conditions on your CO2, your ventilation can't be that bad. It gives you also important metabolic information, even more with volumetric capnography. And of course, you see your resuscitation efforts, because when you get during the resuscitation to a certain and sufficient level of CO2, your resuscitation is on a good course and you are effective. Also, when there's no CO2 coming back, something must be wrong. And last but not least, there is really no contraindication for using capnography. None, nothing, nada. So if you're insecure using CO2, get a training, look at this training, look at other trainings available, read about it. Also the IFUs of the Capnometry manufacturers, they also give you lots of hints and tips how to use it. So there is really no contraindication for CO2. Maybe a little bit the Dead Space edition, but that would be the only one. Now directly talking about the capnography sensors of the bellavista. At the end, you will just get a more insight in how to use them and also how to troubleshoot. Talking about mainstream, and again, we have no delay in measurement, no waveform deformation due to the sampling method. We don't need to remove the water because we don't work with filters like on the Sidestream. And some don't have filters, they have little water traps. And this is very important, volumetric capnography is only possible with mainstream capnography. So if you want to do volumetric capnography with Sidestream, this won't work. So you need to have mainstream capnography. There are disadvantages. Of course, the sensor is exposed. It adds weight to the circuit system. And in my experience, we had a pediatric ICU where they wanted to use mainstream, but they changed to Sidestream again because it added so much weight for the little children and infants that the handling was not very good. And so they decided to go back to Sidestream because it's some grams adding, and sometimes this can be already enough. It's sensitive to fluids and also aerosols, so nebulizing and also a non-sufficient heating system or a heated breathing circuit can make your life very complicated when you use mainstream capnography, and it adds to the dead space. So working with the IRMA sensor, which we are using, always operate the sensor upright. Do never put the sensor directly on the tube. You could connect it this way, but there needs to be a bit of a distance between the sensor and the patients, and also to prevent secretions in the sensor or the sensor adapter. And the sensor can, over time, get very hot, so never put the sensor directly on the skin. So the sensor temperature, maximum temperature during use is up to or more than 50 degrees of Celsius. And do not use a nebulizer. I get the question very often, can we use, why can't we? It's not prohibited. You can do and use a nebulizer, but you should be aware that there will be erroneous measurement during that time, and depending on the drug you are using, this could also have an effect on the adapter, so that you might have to change the adapter after nebulization. But nothing's bad. Nothing bad is happening to the patient, but your measurement will be potentially erroneous. perform calibration when you have a new patient or a new adapter, when the CO2 display is not showing 0% or 0 millimeters of mercury, when you're just holding the CO2 in the air. And bellavista is suggesting to calibrate the sensor. These are the three reasons to use a calibration. You can go into the calibration assist on the second page of the main menu. Calibration of the CO2 sensor takes a few seconds, maybe 4 to 5 seconds, and then you can just start again. And also the sensor needs to have a very short warm-up time. Usually some competitor sensors take up to 2 to 3 minutes until they have warmed up and are ready for use. This one takes 10 seconds. And so the sensor is very fast to be used, because phase-in sensors, they're coming from the emergency use, and so they always try to be the fastest to be in use. So 10 seconds, I think, is very fast. And this is how you use the mainstream sensor. Sidestream again, because the sensor is not directly at the bed, it's more at the ventilator, so the risk of damaging the sensor is lower. Can also be integrated in ventilators directly or in anesthesia machines, but I'm not aware of any ventilator who has an inbuilt Sidestream capnography, but this might be possible. And you can use it also with non-intubated and non-ventilated patients. Bellavista can also be used in capnography during standby. You can just access the cockpit, and when you have a patient maybe on just oxygen therapy and you have a special prong with a CO2 measurement, you can also use the Sidestream capnography and have CO2 measurement while the ventilator is not in use or not running. It can be in standby. Same also for SpO2. So you don't have to ventilate when you want to have SpO2 or CO2 measuring on the bellavista. You need a special sensor for the water removal on the Sidestream capnography of the ISA. I always get confused with ISA and IRMA, so I always have to think about a second what the name of the Sidestream is. You need a special sensor. I will show you this in, I think, a few slides. And due to the sampling line, there is a measurement delay and no volumetric CO2 possible. When you connect the ISA to the ventilator, there is a ring on this one here, and it starts flashing red, and after 10 to 15 seconds it switches to constant green, and then you can start to use the Sidestream sensor. If you want to check that the Sidestream is working, just breathe over the sampling line, and then you should get some measurements. And you can also check the occlusion alarm when you close the line, and then you should be ready to go. And same here, when using a nebulizer, this can also be aspirated into the sampling line, and over time this can also lead to problems with the filter. And so also nebulization, it's not forbidden, but it can cause problems while using side or mainstream capnography. The 0-point calibration is done by the ISA automatically, so you don't have to calibrate this one. It's performed 1 to 3 times a day, and the ISA decides when this needs to be performed. And you might, it's rather unlikely, but when you're present at this moment, you have maybe one breath of no monitoring, and then the monitoring starts again. And this is done 1 to 3 times during the day, and most people have never seen it. That the ISA is calibrating, so you don't have to take care about using it. Now talking about the Nomoline, which is the sample line for the ISA. So at the end, on the connector for the ISA, you have kind of a filter system, a separator for water, and the water is evaporated into the atmosphere over time. But when there is so much fluid ingress that this evaporation process is not working anymore, then you will get a message from the ventilator that there is an occlusion. There is also just in front of the connector here where the water bacteria filter is, there is what they call water fuse. So if the water is just too much in the system, the fuse blocks immediately, and then the sensor is closed, not the sensor, the Nomoline is closed, but the sensor is protected from water and fluid. And then you have to change the Nomoline, exchange with a new one, because you can't get this working again. So this maybe needs to be changed during ventilation when you ventilate over days from time to time, especially when there is lots of water or nebulization involved. Okay, so now the indicators, you always have an LED on the mainstream, you have the LED ring on the side stream, and when it's a steady green light, everything is fine, and the capnometer and the capnometers are running well. When it's blinking, this is indicating that you do a calibration. When there is a steady light, there is a sensor error. This can have different problems, but you know that the sensor is not working, so the sensor is showing red, and the bellavista is also alarming that something's going on or is not correct with the capnography. And when there is a blinking red light, you have to check or exchange the adapter, either the Nomoline on the side stream or the capnography adapter on the mainstream. So these are the four in the, or there is a fifth one. When you have a steady blue light, there is anesthetic agent present, which is not good because this will affect the CO2 measurement. So these are the 5 states, and so you can easily identify what's going on. Mainly you have a blinking red light and a steady red light when things are not working well, but now you also know the difference. So if it's blinking, just replace the line. There's also an alarm on the bellavista that this is mainly something with occlusion, and so you know that you just have to change the adapter. Here are the 5 alarms which can occur on the bellavista. Mainly it's the calibration alarm. There is no adapter placed in the gas sensor because then you can't connect it. And also that the measured values are out of range. This won't happen very often. And also when you forgot the sampling line, and then there is ID 249. When the sampling line is clocked, this can happen, for example, on the side stream. And so there's also the troubleshooting behind that. Questions?
Yes, Christian, thanks very much. I would like to take this opportunity to ask a question that's coming from Khalid. What about transcutaneous PCO2 comparing with mainstream and side stream? What's the advantage and the disadvantage?
The advantage of the transcutaneous CO2 is mainly on non-invasive, because whatever we do on side stream or on mainstream, when there is leakage, we can't guarantee that the CO2 measurement will be perfect, because we don't have the full information of the air, of the exhaled air of the patient. This is the big advantage of the transcutaneous measurement, because it's not relying to air or to leakage, because it's measuring in a quite complicated process the CO2 level of the skin. And so this is the big advantage. The disadvantage is that it's mainly a standalone device, not the cheapest one. And also there can be lots of things when patient is sweating, patient has fever. So this can also impair the measurement of a transcutaneous CO2. And but in non-invasive ventilation, it has a big advantage. So I know hospitals which use mainstream on invasively ventilated patients, and they use transcutaneous on non-invasively ventilated patients. Also, you see transcutaneous quite often because of the application in NICUs, and so it has advantages. And the disadvantage is calibration process is rather cumbersome to date, and there's also chance of erroneous measurement, because when the skin is sweaty, too warm, too cold, the measurement is also impaired by when using transcutaneous measurement.
All right. Thanks a lot, Christian, for answering Khalid's question. The next one is coming from Subnil. Which will give more advantage, mainstream or side stream?
As I said, it really depends on what you're after. If you're just fine with having End-Tidal CO2 measurement and you want to protect your capnometer, and you have adult patients, so you don't have to care about the aspirated air taking from the Sidestream device, Sidestream is fine. So it's mainly used in anesthesia, where the patient also, where you won't expect the leakage as well, and you don't non-invasively ventilate the patient. So this is the perfect use for a Sidestream. But if you want to have additional information, a better CO2 curve, and want to analyze more, and also have the chance of volumetric capnography, I would always recommend mainstream measurement.
Thank you for that, Christian. Another question from Subnil is, what is the shelf life for the adapter and sampling lines? And when we need to change the accessories used on patient, means what is the recommended time frame for one sample line and adapter?
That's a good question. I have to pass on the shelf life. I think it's 3 years, but I'm not 100% sure. I have to take a look on this. When do we have to change the mainstream adapter? Up to 14 days, but usually you change the whole circuit after 7 days, but it can be used up to 14 days, but only on one patient, not interchange between patients. And the Nomoline can be used also for the same period, but my experience with the Nomoline is that, especially when you're actively humidifying, that you might get water problems earlier. So from my experience, you need to exchange it usually every few days.
All right. And here's a question from Vishal, please. What are the metabolic information we can get from capnography?
This will be entirely discussed and shown in the capnography part 2, which we have in August. And then we will talk extensively about the opportunities and also the metabolic information you can get out of capnography for the time-based capnography, which we discussed today. You see the End-Tidal CO2, which also gives you the indication if you are hypercapnia, hypocapnia, because this also leads already to metabolic information as well. But the main metabolic information and how is my patient ventilated or how good I am in ventilating patients will come from the volumetric capnography. And this will be shown in August.
Yes, like you already said, next webinar, Capnography 2. Thanks very much, Christian. It will be at the end of August, and we are going to announce it to you very soon. So here I have a question. We are continuing with Ankur. Nomoline is reusable one or single use, you would like to know?
Some months ago, we had a reusable one, so this could be used until it wasn't working anymore. But unfortunately, because it was quite popular, unfortunately, Massimo discontinued this. So currently from Massimo, there are only single patient use Nomolines available. So the reusable one is not available anymore.
Thanks, Christian. Now, Ahmed is asking you to explain the benefits of volumetric CO2, please.
I really try to condense it next time in 1 hour because there are so many. But of course, I think one of the biggest benefits, just to give you a teaser, is that you have lots of opportunities to see how your ventilation can be optimized. And sometimes you think that you're ventilating in a good way, but the volumetric capnography might tell you something different. And this is the biggest benefit of the volumetric capnography. But how this works, because you could talk hours about this, I will explain in the next webinar.
Good, thank you very much. Another question from Subnil did come in. Can we use the same adapter for all categories of patients?
On the Nomoline, there are 2 different adapters for neonatal with less dead space, and then the adult pediatric version. And the same with the mainstream. We have a capnometer for adults, and there's also a pediatric, not a capnometer, sorry, an adapter for adult, and there is also a pediatric adapter with also less dead space. So there are always 2 choices with each device, so either for infant and adult or for pediatric and adult.
Great, thanks, Christian. Our last question is here, and that's coming from Mohammed. What are the main challenges in monitoring of EtCO2 in neonates, please?
So that's the reason why so many NICUs are working with transcutaneous, is because usually you don't block the cuffs. Sometimes now in the past they are starting to block cuffs of the tubes of the neonates, but still there are still, I think the majority are not blocking the cuff, and so you have constant leakage. And if you use Sidestream and having leakage during exhalation, it's the same like in non-invasive ventilation. You will get some CO2 level, and if you are able to keep the leakage constant, you might get information out of it. But that's one of the biggest challenges, that you can't be 100% sure how was the leakage or how is the leakage. So trending will be difficult, and because you never know what is where you came from. So in the hospital here in Switzerland, they're using simultaneously Sidestream capnography on their neonates and at the same moment transcutaneous, and they somehow average this so that they know, okay, transcutaneous might be, depending on the status of the baby, a bit too high. Sidestream might be a bit too low, so the truth must be somewhere in between, but this is a very luxurious approach. But the main challenge, as already said, is the leakage problem.
All right. Thanks very much for your answers, Christian. That was it. No more questions from our participants. Thank you.